Okay. Well, good evening, everybody, and welcome to our last webinar for this season. And tonight, we saved the best speaker for the last. We have Professor Keith Roberts joining us from Birmingham, talking about liver transplants. And I'm sure everybody knows Keith very well in the HPV and transplant arena, so I don't think we need much more introduction than that. And we've got a really exciting talk lined up, and I don't want to keep everybody waiting. So if Keith, you're happy, we can kick off.
Ben, thank you so much. And yeah, thank you for the introduction. You're very kind. So yeah, thanks to Ogis for the invitation to speak. Yeah, it's nice to see myself in a webcam and see just quite how bald I'm going. My kids keep teasing me, "Daddy, Daddy, why are you going so bald?" And I look at myself in the webcam, and yeah, unfortunately, they're right. Anyway, I'm wandering. So I'm going to give you a talk about some seminal papers in liver transplantation. To kind of set the scene, I'm going to give just a brief history of liver transplantation because, I mean, surgery and what we do is a fascinating subject. And, HPV surgery and liver transplantation, these are really quite new surgical procedures. And so the history and the evolution is really, well, fascinating. And, where we've learned so much from where we've come from, and the papers I'm going to highlight are also a bit of a history of liver transplantation. So, if I can get cracking. So, liver disease is a huge problem in Western societies, and deaths from liver disease is just going up and up and up compared to other liver disease. So, the burden on healthcare is huge. And as you know, we don't have a machine that can perform dialysis for the liver. We don't have an ECMO for the liver. If your liver fails, there is not a replacement. So transplantation, organ transplantation, is a complete revolution of surgery. It's a very entirely novel strategy to take a body organ from one person and put it into another. I mean, it's just remarkable when you think about it. The person that really pioneered liver transplantation was Thomas Starzl, and he started with animal experiments. And the first liver transplant in humans was in '63. But the problem is, well, there were lots of problems. So by several years later, they got to their first 12-month survivor. And in 1973, after nearly 200 liver transplants, only 15 recipients had survived longer than a year. And Starzl describes kind of what must have been an incredibly difficult scenario. There's no ligature, there was no thromboelastography. The anaesthetists were not using hypotensive resuscitation. They were pouring fluid in. And he described the operation is simple in principle. It is simple, isn't it? It's just joining pipes together. But its execution has been exceptionally difficult because of the almost invariable debilitation of the recipients. They've got end-stage liver disease and the profoundly abnormal vascularization patterns caused by portal hypertension. Defects in clotting have been present in most cases, and adhesions or other alterations secondary to previous surgery are often complicating factors. And what he says is that with such a background, it is not surprising that the post-operative care of patients is really an exercise in resuscitation. The ability to survive this critical period depends on what happens in the operating room. And in the first procedures, what they would do is systemic and portal venous bypass. So the whole vena cava would be removed, and the portal vein would be removed, and you'd have a venous bypass. Um, it was found early on that the portal bypass was not necessary, but it's described that you have gross swelling of the bowel, and you know that you get this if you have temporary clamping of the portal vein. And in this early series, you can see some really interesting things that they did. Initially, the gallbladder was anastomosed to the duodenum. Here, a donor celiac artery is anastomosed directly to a donor aorta to take care of aberrant arterial anatomy. Here's another picture of aberrant arterial anatomy. And these are practical solutions to problems that Starzl found at the time. Because of infectious complications from anastomosing gallbladder to duodenum, that very quickly changed to a duct-to-duct or Roux-en-Y reconstruction. What really changed, though, for liver transplantation to make it mainstream were two game changers. And the slide is a bit old, okay? It is the SAS of Sturridge and Suarez. The two game changers were immunosuppression and control of hemorrhage. So with involving surgical technique, Starzl described improved survival with liver transplantation, but really patients were dying because of rejection and rejecting their graft. And it was only when cyclosporin, and this study is from Cambridge and Roy Kahn, when cyclosporin became available, that rejection really had a treatment or could be avoided. And that was the first thing. That's key. And in bleeding, surgeons have learned technique. Anaesthetists have learned technique. I'd mentioned thromboelastography. The trauma surgeons are trendy. They think thromboelastography is new, and they're like, running around the place excited about it. It's the liver transplant surgeons and anaesthetists that had thromboelastography, and we've been using it for decades. But if you look at back at the papers, so Pittsburgh in 4 years went through nearly 19,000 units of blood for 636 transplants. And in Cambridge, they'd often have to shut the liver transplant program because the blood bank would literally phone them up and say, "We've got no more blood left. You cannot transplant any more patients." This was how remarkable the bleeding and issues were. And here is a photograph of outside the Birmingham Theatre in the 80s after liver. This was fairly typical after liver transplant. So as we've learned and it has become mainstream, so we've refined our technique, and there are things that are outside this talk about how we control hemorrhage and things, but a little bit I'll come to. But you can see here the medium blood product use in the first 300 liver transplants in Birmingham goes down with learning skill, and so we've adapted techniques. Onto the seminal papers. So the first paper I'm going to talk about is Belgitti's paper on temporary portocaval shunt. So I spoke to you about venous-venous bypass, and I said that you don't have to do a portal systemic bypass. But what you can do is create your own portosystemic bypass. So one of the very early tricks the liver transplant surgeons learned was to divert the divided portal vein down onto the vena cava, anastomose it there, and with preservation of the vena cava, you then have all the portal flow, all the systemic venous return going back to the right side of the heart. And all of a sudden, if you learn to take the liver off the vena cava rather than have to take the whole vena cava out, all of a sudden you don't need any veno-venous bypass. And this makes it safer, makes it simpler, and reduces complications. As we've got quicker with liver transplant and hepatectomy, you don't need to do a portocaval shunt routinely now. It is good when you start to do it in every case. It reduces bleeding, it gives you skill of doing an anastomosis, and then when you need to do it in acute situations like paracetamol overdose, when you absolutely have to do it because you don't have established shunts, then you are slick at it. It also helps to take the liver off the cava if you've divided the whole hilum. If you've still got it running on the portal vein, it's a bit more tricky. So this was a great paper, and it shows the ingenuity of surgeons. The next was the split liver transplant. Liver surgeons are, we benefit from having this incredibly complicated anatomic structure, which in some ways is simple. There is a right and a left half. It's just buried within the surface of the liver. And so the first split deceased liver transplants were reduced sized grafts for children. So the problem that the children have is that most donors are not pediatric, most donors are adults. And so how would a small child have a liver and have a chance for liver transplant? So the first grafts were reduced. So they basically threw away the right side of the liver and just transplanted left lateral segments. And these were reported simultaneously in 1984 by Bismuth and Brolsch. But then you realized after a while that throwing a right lobe away was potentially a waste. And so the first reports of split liver into two recipients, one adult, one pediatric, was by Pickelmeyer in 98 in Hanover and Brolsch in 88. Now, early experience had slightly higher um, patient and graft loss than whole liver transplant, and there was a fairly powerful paper from the University of Chicago, which really put a bit of a dampener on split liver transplant. But John Deville de Goyer in Europe published 100 grafts with acceptable outcomes, reinvigorating interest in split liver transplant. And it is now, this really the standard of care for a good DBD graft to split it into two and offer the left lateral segment to a pediatric population and the right lobe to an adult population. There are two planes for a split. So the first plane here is shown in B, and it's not quite down the falciform. It is just to the right of the falciform, and that preserves the inflow to segments 2 and 3 and the outflow via the left hepatic vein, and the segment 4 stays with the right lobe. Now, if you've got your thinking cap on, your segment 4 will have lost its inflow because the arteries and the portal flow come in from the falciform into 4A and 4B here, but they are divided. The outflow is still there through the middle vein, but essentially you end up with a devascularized segment 4. So some surgeons will remove segment 4, some just leave it on. And this leads to some of the complications of split transplant, which are infections and bile leaks from the cut surface. Very few cases describe a split down the principal plane and two adults receiving a full right or a full left graft. There are very few case series of those. And these figuratively are what a split graft will look like. Typically, the left duct is cut short on the donor. The artery, normally the left artery with the common hepatic would go with the pediatric, and the right artery is cut short normally. So surgeons have learned to, do some really fascinating things. Early on, this is a Birmingham paper, I think. Early on, we had a slightly higher increase of vascular complications with splits because the artery is more narrow, more venous outflow obstructions, and more bile leaks. And the Birmingham team in the early noughties published the importance of using a T-tube in the bile duct to take the pressure out of the biliary tree, and that reduced complications of the cut surface. One thing that you have to look out for in a split is an aberrant right posterior sectoral duct. And here you see the naughty thing coming across and inserting into the left duct. And here you see a cholangiogram where you only have a right anterior sectoral duct. So the bad thing has happened to this graft. But with experience, the survival, graft and patient survival of split and whole livers are entirely similar now. So it's particularly helped pediatric population. The natural evolution of deceased split liver transplantation is then live donor liver transplants. And when you think how seminal this paper was, this is the paper in its entirety. This is the world's first description of two live donors summed up in 3 paragraphs. It did make it into the Lancet. There's absolutely no description of technique. It just says what happened to the kids. So Raya described 2 left lateral segment donors, a 4.5-year-old who unfortunately died on post-operative day 6, from what I read as a mismatched blood transfusion, and then a 19-month-old who had a 40-year-old altruistic donor because there was no family member who were able to donate. The baby had delayed graft function, and the bilirubin was 550. And when we look back, it's probably due to extended preservation injury. This operation took a long time. But live donor liver transplant is the only option in many Asian countries. And I would suggest that live donor liver transplant is the absolute pinnacle of abdominal surgery. The technique, the refinement, and the skill required is the absolute peak. And it's taught us things about graft to weight ratio. It's taught us how to manage portal hypertension, ligating splenic artery, giving octreotide infusions, even doing hemiportocaval shunts. It's all about small for size. Things that we talk about in HPB surgery are complications that we see. The live donor liver transplant surgeons have done it all, and they've described it very well. And essentially, small for size is what these guys have described, and they measure the portal pressure, and then you will modulate things to reduce the portal pressure so that the graft is okay. Improve Outcomes have improved over time. It makes sense. Um, there is obviously the issue with live donor of transplant tourism and the selling of organs, and also in China, not necessarily the selling of organs, but how organs are procured. And there have likely been thousands of donors taken from prisoners who've been executed. So it's a little bit there's a part of this that is very unsavory. So let's talk about graft risk. How do we know which graft we can use? So back in the day, it was very difficult. You want to transplant a liver, but the liver has to work. And we don't have a backup plan if it doesn't work other than emergency retransplantation. And so the most cited paper in liver transplantation is this paper here, which is characteristics associated with liver graft failure, the concept of donor risk index. So this is an American paper, and this predates any machine perfusion. So this is before we could assess a liver function. You had liver blood tests at the time of donation, but we had no way of assessing the function. So over 4 years, it looked at 20,000 liver transplants in America, and it looked at predictors of graft failure, either time to redo liver transplant or time to death. And they looked at 31 donor factors, and I won't go through them all, but they're there. And it looked at adjusted outcomes, adjusted for recipient and transplant factors that could affect graft survival. And here are those factors that they adjusted for on the recipient side. So a lot of data, a lot of adjustment, because obviously there is a huge amount of interplay between all of these things. There was a very low number of splits and low number of DCDs because of the period. Most patients were dying of trauma and stroke, prevalence of hepatitis B and hepatitis C, and they identified 7 independent donor factors: age, African American versus whites, donor height, cause of death, CVA or other, DCD, and split. And then this is how the donor risk index looks for these different factors. And there's different weighting for the different things. And then there are 2 transplant factors that are independently associated with poor graft function. And that is increasing cold ischemic time and sharing outside of the local donor surface. And these were added into the model. And this is what the DRI looks like with graft survival. So as the DRI increases, you have worse graft survival. But if you look, it's not particularly discriminatory. Most grafts that have a high DRI, well, most, over half, will still be going at 3 years. And most grafts that have the highest DRI, well, 15, nearly 20% of those are lost. So it's not massively discriminatory. But the problem is liver transplantation, liver donation is very much dependent upon the population and the society in which it is performed. So as I showed you, live donor liver transplant is unique in Asian populations, and they are absolutely expert, and we do very little in Western populations. I mean, here you have an American population. You have American Africans. You have other factors in there, like sharing outside of your zone. They are not transferable outside of the USA. There were also very low numbers of DCDs, very low numbers of splits, and they were very early in the program, and so not necessarily representative of what we were doing in the last decade or so. And with the advent of machine perfusion, DRI is less useful, and we're going to come to this. In fact, here we are. We've come to it. So we've come forward a couple of decades now, and this is the COPE trial, a UK study, a randomized trial of normothermic preservation in liver transplant, led by Peter Friend in Oxford. So why do it? Well, I've just shown you that if you try to work out which livers will or won't work, it's not terribly discriminatory. You will get livers that should perform really well that you will lose, and you will get livers that on paper look terrible but will survive fine. And it's all a lottery. The problem is you stick a liver into somebody and you don't know it's going to work. That patient gets delayed or primary graft non-function. It's obviously an absolute disaster. So machine perfusion allows to assess an organ's function. And it also helps to extend the donor pool because you can start to take risks. Well, you're not taking a risk, you're just sticking on a machine, right? You're going to take a liver that maybe you'd have turned down before, but you're going to put on a machine. It was not very ambitious with its primary outcome. Okay, so if you do a trial, you want your trial to be positive. Okay, so their primary outcome was the difference in the peak AST within 7 days of transplant. Now, I don't really think that a peak AST is of an awful lot of direct clinical relevance in liver transplantation outcomes. Okay, and it was a pretty safe bet because if you have a less ischemic injury, you're going to have slightly less cell death. So they didn't really push the boat on this one. But it is a groundbreaking trial. It's a large trial, 334 livers. It allowed inclusion of DCD and DBD. They had 4 hours on the machine, and they also looked at bloods and 6-month MRCP to look at biliary injury. And it was interesting. I mean, I was around when we were doing this in Birmingham, and first of all, there was a much higher discard rate in the static cold storage group, 24 versus 1. That's not right, is it? 1.6%. It's half. Okay, so there was half the discard rate in the normothermic machine perfusion group, and that tells you that it works because the liver it's on the machine. The surgeons could see it was working. They had confidence in the graft, and they were transplanting it. But what we were also learned to do over this trial was actually push the boundaries, and we started accepting fatty livers. We did not know at that point if they were going to go in control or intervention arm, but we knew they had a 50-50 chance. So if we had a fatty liver and it was randomized to cold storage, then we knew it was probably going to go in the bin. And so that's part of this is not how trials should be done, but it tells you that the surgeons had confidence in the technology. Obviously, the preservation time was longer in the NMP group. The median perfusion time was 9 hours. Post-reperfusion syndrome, higher with cold storage. Lactate after transplant, higher with cold storage. The need for vasopressors, higher with cold storage. Reduced need for vasopressor and reperfusion syndrome, higher with cold storage. No difference in biliary complications, accepting that we took more risks with the NMP group, and a lower bilirubin and creatinine with normothermic perfusion. And here is your primary outcome, a very exciting halving of the AST at day 7 in NMP. DCD was more impressive. You can see a much more reduced AST compared to cold storage. And lactate on the machine. So the machine, it works, the liver clears lactate. And so this is a practice-changing study. Early confidence with the machine meant less organ discard, and it means we can use organs that we would otherwise not use. And this paved the way for expanding the use of this into livers that otherwise we're going to go in the bin, which is the Vital study, and also for doing marginal grafts into marginal recipients. That's one of the old rules. You don't put a marginal graft in marginal recipient. Here we were using marginal grafts and sticking them in patients having redo transplant, for example. It also facilitates multiple transplants at the same time, so you can accept more than 2 livers because you can just stick one on the machine whilst you're transplanting the first. And it also may bring about daytime transplantation. And the NHSBT is looking at something called SCORE, which aims to retrieve overnight transplant daytime. This could facilitate it even more. And for those entrepreneurs out there, Organox got sold to Terumo in 2025 for £1.2 billion. And this was a University of Oxford creation. I think it's the last paper. Hypothermic machine perfusion, a randomized trial. So another randomized trial, another machine perfusion. So DCDs are going to potentially be the savior of liver transplantation in Western populations. Okay, if we're not going to do live donor transplant, the number of brain dead donors is not really going to go up, and the vast majority of people do not die after brain death. So we need DCDs. The problem with DCDs is nearly 1 in 5 patients who gets a DCD has this. And what you see here on this MRCP is loss of the central bile ducts. Okay, this is ischemic type biliary lesions, and it's a disaster. It gives awful quality of life, readmissions, hospitalizations, and ultimately the graft is knackered, and it leads to either retransplantation or death. So 1 in 5 patients who have a DCD have this awful outcome. Non-randomized data suggested there'd be lower rate of ischemic biliary lesions with HOPE. HOPE is hypothermic oxygenated perfusion, and it's a very simple concept. Is that during cold storage there is a loss of energy and ATP within the mitochondria, and this leads to irreversible damage. You could do normothermic machine, and you can put blood through and try to facilitate entirely normal metabolism, but perhaps you don't need to do that. If you can just get a low level of oxygen in a cooled liver, the metabolism is not going to be going 100%, but that low level of oxygen allows maintenance of ATP, and it allows the hepatocytes to basically not go into irreversible death. It was a one-to-one randomized trial of dual HOPE. There is single HOPE. Single HOPE is a piece of cake. You put a pipe in the portal vein. That is it. Dual HOPE, pipe in the portal vein and a pipe in the hepatic artery. So this used the ex vivo liver assist device here, and cold storage was obviously the control arm. Perfusion at 10 degrees for 2 hours. And the primary outcome here is a more exciting primary outcome, more clinically relevant outcome: ischemic type biliary lesions at 6 months. 160 patients power calculation, and 6 centres, and then block randomization to ensure equal allocation of patients with different diseases. And look at the difference in ischemic biliary injury rate. Huge difference, a third less in the intervention arm. Also reduced post-reperfusion syndrome, and 2 different definitions used. It doesn't matter which definition, there is a reduction in post-reperfusion syndrome and a reduction in early graft dysfunction. And this was an absolute practice-changing study. HOPE is cheap, it's simple, and it is absolutely the standard of care in DCD. Some centres will use NMP instead. There are randomized trials to be done to find optimal techniques and optimal machines. But what I hope you've seen is that due to ingenuity of surgeons, we've adapted surgical technique. The HPB surgeons have learned an awful lot from liver transplantation, splits, live donors, and so on. And surgeons have then gone and we've learned to use technology, and we've learned to really push the boundaries of understanding donor risk, and also mitigate injury during donation and transplantation. So I hope you found this talk interesting and useful. A little pitch. If anybody wants to do a PhD, we've got some lovely PhD slots in Birmingham. You can do liver transplantation, you can do machine perfusion, pancreas cancer, gut microbiome, pancreas fistula. If you want to do a post-CCT fellowship, we have those in liver transplantation, we have those in HPB surgery, and we have a great team in Birmingham. So anyway, thank you for my pitch, and thank you for listening.
Well, thank you very much, Keith. That was absolutely breathtaking, and I'm sure the audience would agree. I can't believe you covered the whole liver transplant in just under half an hour, actually. Not half an hour, under half an hour.
I know you were telling me off at the start. I could feel the pressure, which is why I was talking so quick. I thought, oh my God, if I go to 7:46, Ben's going to cut me off.
Yeah, yeah. I'm known for that as well. For the audience with us live tonight, you can post your questions in the Q&A section, and I can ask that. I can ask Keith for you. It's at the bottom right. There's a little box with a question mark Q&A. Whilst we wait for our attendees to warm up and post some questions, I think I already told you earlier. I was like, you know, this is fantastic. Like, to me, machine perfusion is the most exciting thing to have happened in medicine during my career. The Organox thing was absolutely amazing. I'm almost a little bit sad it got sold to I think it's a Japanese group, isn't it? I was like, oh, another great British invention that has been sold. I was a little bit sad, but well done. It's absolutely amazing invention. How do you think we will achieve a 9 to 5 job for transplant surgeons in the distant future? Is my first question for machine perfusion.
Um, yeah, it kind of feels wrong, doesn't it? your liver transplantation needs to come with a good dose of insomnia and sleep deprivation. Um, I think it will. I think it will help. And I mean, certainly, if we've got a difficult redo now, we will, and we can't get the sodding donor team to delay, then we will put it on a machine so that we can do it in the daytime,
Mm,
when somebody else is around, just in case. And these are long transplants. These are long operations. A redo. It's 4, 5, 6 hours.
mm,
Usually, and if you're unlucky, you're going to be a little bit longer. So there's certainly a logistics issue, and something that we have in Birmingham, which some of the people will have, is we may not have a guaranteed ITU bed, and we
mm,
have to wait for a certain time. So there's that, and as I said, particularly ourselves and Kings, very often there'll be days when there are more than one liver on the go. Sometimes you've got three, and if you don't have machine, you you can't stick them all in at the same time, and they're getting well, they're not getting warm, but they're getting cold, and they're just going bad in the bucket, and that's not good. So we can stick one on Hope, we can stick one on NMP, and we can do um, the third one. So yeah, I mean it's brought a lot of flexibility into it, and it also brings a lot of confidence. Um,
mm,
you know, it, it really, it really was a black art. And in fact, well, one of the most exciting things about liver transplantation was taking your donor and going, right, well, who can I stick it in? And it depended how brave you wanted to be. If you had a 20-year-old fantastic donor, it's not right to stick it in a young, fit and healthy PSC or PBC.
mm,
You've got to put it in a very difficult patient. But if you've got something that's a bit risky, you know, this
mm.
kind of obviously this makes it safer for everybody, which is
Mm.
better. Um, so yeah, it's really changed things.
Do we have any data how much liver transplantation has increased because of machine perfusion?
It's a good question. So if you look at the annual numbers we're doing in the UK, we're actually doing less.
Oh, right.
Yeah. So COVID was a big problem,
Mm,
and the public's kind of benevolence. Everyone's become a little bit more selfish after COVID.
mm,
Donation rates are lower,
mm,
and that's a little bit um, multifactorial.
mm.
So machines are allowing us to basically still transplant despite having a lower donation rate. So
Okay.
if yeah, so I think if you took out all of that, I'm sure we'd be doing more transplants
Mm,
because of machines. There's absolutely no question.
mm.
Um, but yeah, there are other things at play at the moment in the UK.
That's a little bit disappointing to hear, isn't it? With the retrieval side of things, with machine perfusion, and yet the numbers have actually gone down a little bit. I wasn't aware of that actually, because
Yeah,
I genuinely thought the numbers have gone up a little bit.
yeah.
Actually,
But
look
so
at.
DBD in particular has gone down. They've slightly changed the brain stem testing
Mm,
protocol, which has made it slightly more difficult. It may, sorry, maybe it's less attractive for ITU physicians to do brainstem testing and keep patients on ITU. Maybe it's just quicker to do DCD. I don't know. But there are certainly less brainstem dead donors coming our way.
that's a good point you bring in. About the brainstem death criteria. I remember revising my FRCS for that and trying to find the latest criteria and having learned the old one by mistake and then having to try to wipe it out of my head and then a new one. So I guess for the younger audiences, let's start with the MRCS first. How much MRCS live? How much? I'm sitting my MRCS and I'm listening to your talk and I'm a little bit having palpitations now, thinking how much liver transplant do I need to know for my MRCS next week? How much
I,
MRCS knowledge do you expect for liver transplant?
I mean, I'm making this up.
Mm.
I'm not an examiner, and it's a long time since I did my MRCS. I am suspecting 0% knowledge would be expected at MRCS.
And FRCS?
Uh,
I can tell you the brainstem criteria is definitely one that people
yeah,
should be familiar with.
yeah,
But for the
yeah,
non, I guess let's split into two for the non-liver transplants declared. So most people will be general or colorectal or something. else rather than liver transplant declared, um, what would you say would be key aspects that you would expect them to know going into FRCS?
I mean, I think the distinction between a DBD and a DCD,
Mm,
um, the basic anatomic principles of the liver transplant, um, the the piggyback anastomosis, how one vena cava is anastomosed to the other vena cava, maybe um, immunosuppression. Um, so we tend to use triple immunosuppression. Most patients use triple or dual immunosuppression. Corticosteroids are vital early on, along with you know azathioprine or mycophenolate, and then the backbone is tacrolimus. And then the corticosteroids are weaned. Some centers will use tacrolimus based only, others will have dual. But cyclists, immunosuppression is obviously a key part of this. Um, Complications of liver transplantation, biliary strictures you've seen, hepatic artery thrombosis, 1% of donors. One important thing we've not spoken about here is cancer risk. So immunosuppression will obviously mean that if you develop a cancer, your body is going to be less able to fight it. Normally, we think about immunosuppression, we think about infective complications, and certainly early after transplantation, there's a lot of focus on looking for infections. But in the long term, if you take 100 transplant recipients and 100 age-matched controls, you will find a few more cancers over here, and that is a real thing. Tend to be skin cancers, but bowel cancer and so on. But I don't think a lot of detail is needed for the exam. Just don't ask me the brainstem test criteria, okay?
I've given that back to my examiners too after they asked me. So you brought on immunosuppression, and that again very conveniently leads on to my next point. Where do you think about the future of xenografts? You know, how
Okay, that's a
can I
good
can I
question.
get my custom-made liver ready for me next Monday?
Not for me, you can't. Yeah, I don't know. I mean, personally, I think it's just too complicated. If you look at the liver and its organization and how you have the portal hepatic artery blood going through the hepatic venous outflow, but then also the bile production. I mean, how can you make that? How can you do it? I know you can devascularize and have a skeleton, a collagen skeleton, but how the hell do you put the cells in the right place and get them to all like form functional units? So I don't know. Can you get rid of all of the proteins off something so that it doesn't raise any antigens? I mean, surely that's not possible, right? Because so or maybe I'm just too stupid and I can't see a way. So I personally don't think it's going to be the solution. Um, in Western societies, we've got live donor liver transplant. There is. I mean, I've just back from Lahore a couple of weeks ago. I mean, it's fantastic. I mean, it's just incredible. Every day of the week is at least one live donor, and they're just so slick and it's so calm and it's very flexible on the day. They do the intraoperative cholangiogram. Oh, it looks different from our MRCP. No dramas. We'll do this. We'll do that. Oh, hang on a minute. It doesn't look quite as big as we calculated. Liver comes out. Oh, it's a bit smaller than we thought it was going to be. You know, we've just modulated the portal flow. It's all very relaxed. I remember we did a few live donors in Birmingham, um, 5, 10 years ago. It was super stressful. I mean, it was really stressful. And there were meetings after meetings before we got near the donors. But so that's one thing that we can do.
Mm,
And then the other thing is we've spoke about is machine perfusion.
mm,
But the biggest thing we can do is to engage with society. And it's a very simple question, isn't it?
mm.
Would you accept a donor organ if you needed it? And if the answer to that question is yes, then really the person has a moral obligation to donate their organs. I mean, it's as simple as that. If you're going to accept something, well, where are you accepting it from? I think society has a moral obligation to do this, and so increasing donation rates, more machine perfusion, more assessment. This is how to expand donor programs.
So that sounds like two PhDs to me, actually. One for the ethical side of things and one for the scientific side of things. So many jobs to come in Birmingham, sounds like. Um, My other question would be again on machine perfusion. I have no shame in admitting my love for the Organox paper. That to me is the most exciting paper I have read in my career. A real
Even
game.
the primary outcome.
Uh, yes, even the primary outcome. I just, first of all, it's in nature. It's what surgeons dream of, right? And I just felt that is a real game changer and has really moved the needle in how we practice liver transplants. So my question is, now we have this amazing platform, and I know you do quite a lot of work, as you mentioned just now as well, in liver transplant research and machine perfusion. Where's the limit of what we can do on machine perfusion, both academically and clinically? How much
Yeah, good question.
preconditioning can we do? Filtering of various harmful proteins, or adding on some good drugs can we do on this machine perfusion platform? Whichever platform it may be. Obviously, I'm a little bit biased towards the Organox one, but any machine perfusion platform.
Yeah, it's a good question. So, what we're currently doing is just observing and having criteria for what is transplantable and what is not transplantable. So, we're not doing anything different. We're just trying to make it safer. There is interest and there are studies out there on defatting the liver. So, one of the biggest problems with a donor is a fatty liver. Steatotic livers they're a bloody nuisance. They don't work well. They really don't work well at all. And so there are people who are trying to get rid of the fat out of the liver, but how quickly can you really defat a liver? And if you think about the organox, it is a perfect culture medium, right? You have warm blood. You don't have a complete and it's open, right? I mean, the bloody liver's sat in a bucket in front of you. You take the lid off and have a look at it every now and again. You have an open circuit, microbiomes can get in there. It's warm, you've got blood. I mean, it's just perfect. And red blood cells, I think they're depleted of white blood cells, aren't they? So every now and again, we'll transplant a liver that's been on NMP, and you get an absolute, sorry, I'm going to say it, shit show. You put the liver in, normally with a machine perfused liver, reperfusion is very smooth. It's just like, but every now and again, you put a machine perfused liver in, and the patient goes just haywire because they've got bugs in there, and you get this big gram negative, or this big septic hit immediately. So, how can you stick something on a machine, run it for days, modulate and do something to that graft, and avoid, it getting secondarily infected? So there are some practical issues with doing interventions to try to expand the donor pool.
Here to share any secret developments in Birmingham? Any new drugs that is developing behind the scenes?
Uh, we're just trying to keep the show on the road at the moment. um, so my colleagues, I mean, my colleagues would do machine perfusion research. So we do a lot of interest in hope from Miss Mateos. We've just appointed two NRP consultants, so normothermic regional perfusion, and they're also going to have a big interest in machine perfusion. So there is a huge amount of interest in this field, and yeah, we have a great team.
This all sounds really exciting, all the things you guys are doing in Birmingham. And, I don't think there are many units in the UK that offer such a comprehensive HPB and transplant program and academic and clinical opportunities. So for anybody interested, you've got the email address there. The door is open literally behind you. The door is literally open behind you. So for those interested, please reach out. I think that quite nicely brings us to time. I don't see any questions from the attendees so far. And I just want to say a big thank you to Keith for your time this evening. And that brings me to two last plugins, if I may. First is there is a joint GBI HPBA with our Spanish society in 22nd to 24th of April. That's in Liverpool. Uh, the agenda is already online and it looks really exciting. The abstract submission was extended. I can't remember if it's still open, but anybody who is interested, please have a look at that. It looks like a really exciting program. And for the trainees who are with us, the next RU Training Congress is 5th and 6th of May in Newcastle. And those who have been before knows that it's a great time to meet other trainees, to network, to understand the lay of the land of HPB training in the country, meet some consultants, and understand where various research opportunities, fellowship opportunities may be coming up as well. And it's just a pretty relaxed weekend, weekday this time. So please have a look at that as well. Abstracts are still open for that Congress, 5 to 6 of May in Newcastle this year. So thank you very much again, Keith, for spending the evening with us, and thank you for everybody who's dialed in half midweek. I know how busy everybody's schedules are, and we really appreciate it. So thank you, everybody, and thank you again, Keith.
Ben, thanks. Nicely chaired.
Hope
Thank
to see
you.
you
Thanks
soon.
for your questions.
Bye bye now.